Hi, everybody. Welcome to Pediatric Grand Rounds. I'm going to, first of all, say Dr. Hirsch had a unexpected thing that kept him from being here today, so he won't be here. My name is Sandrine van Schaik. I'm the Vice Chair for Education in the Department of Pediatrics. And before I introduce our speakers for today, I want to do a quick but important acknowledgement. We would like to acknowledge the Ramaytush Ohlone people who are the traditional custodians of this land. We pay our respects to the Ramaytush Ohlone elders, past, present, and future, who call this place the land that UCSF sits upon their home. We are proud to continue their tradition of coming together and growing as the community. We thank the Ramaytush Ohlone community for their stewardship and support, and we look forward to strengthening our ties and we continue our relationship of mutual respect and understanding. And I just wanted to highlight that, especially in this day and age, mutual respect and understanding is so important. So I wanted to pay a moment of attention to that mutual respect and understanding. For people in the live audience, a little delay in getting lunch here, but feel free to get up and get the lunch during these introductions. For people on Zoom, welcome. I'm sorry that we have no way of delivering lunch to your locations. It is my honor to introduce today two speakers. Who are both from UCSF, the Department of Psychiatry. Our speakers today are Drs. Margolis and Kian. Dr. Margolis, Kate Margolis, is an associate professor of psychiatry and pediatrics and is the director of the Division of Integrated Behavioral Health at the Zuckerberg San Francisco General Hospital campus. She's a Spanish-speaking licensed child clinical psychologist and leads the Integrated Behavioral Health Program at the ZSFG Children's Health Center, which includes the Healthy Steps services. Dr. Margolis specializes in the implementation of pediatric primary care, integrated behavioral health programs, and brings expertise in Medicaid financing and sustainability to this work. She has directly supported the implementation and uptake of pediatric integrated behavioral health services to over 50 publicly insured pediatric and family clinics across California and Colorado. Dr. Margolis was leading collaborator in the development of the new medical Dyadic benefit and is the founding director of the UCSF Center for Advancing Dyadic Care in Pediatrics. She became interested in the specialization of pediatric primary care psychology because it combined her interest in perinatal and early childhood mental health with meeting families in their natural environments to promote access to care. Dr. Chen Quan is an assistant professor of psychiatry at UCSF and a licensed clinical psychologist at the Children's Health Center at ZSFG. Dr. Quan's clinical interests include pediatric primary care, early diagnosis and treatment of neurodevelopmental disabilities, and culturally sensitive dyadic interventions. She's a passionate advocate for early childhood mental health services, especially in underserved communities, in both the US and internationally. Dr. Kian received her PsyD from the PGSP Stanford PsyD program. She completed her pre-doctoral internship in child psychology at Children's Mercy, Kansas City, and her postdoctoral fellowship in neurodevelopmental disabilities at Cincinnati Children's Hospital Medical Center. Dr. Kian also holds a master's in education from the Harvard Graduate School of Education, so incredibly well trained, and we're very, very grateful that they are here together to talk to us about pediatric behavioral health services and early pediatric visits with a talk entitled Babies Don't Go to the Doctor by Themselves. Welcome.
Hello, good afternoon, everybody. So I am Dr. Kate Margolis, and it is a pleasure to be here this afternoon. Before I begin, I just want to say we have so many people that we collaborate with. That is really the nature of integrated care. And so wanted to put them all up here in acknowledgement, knowing that probably not everybody who we need to acknowledge is up here, and I won't go through all of them, but I just want to say, especially to our patients and families that we work with at the Children's Health Center, we really are standing on all of their shoulders. Our goals for today are to talk to you about pediatric integrated behavioral health and specifically in early childhood. And so first, we want to talk through what the unique benefits are of doing integrated behavioral health services within early childhood well-child visits. We will talk about the different components involved with integrating behavioral health, promotion, and prevention. And then finally, we hope to begin to develop an understanding of what the new dyadic billing mechanisms are and other preventative billing, behavioral health billing opportunities are via Medi-Cal. And first, we'll start by providing some background context, both about our clinical operations and what's going on in California that sets us up nicely to be able to do this work. Then we'll do a deeper dive into what is early childhood and perinatal mental health and how do you do that in primary care. We'll talk specifically about our programmatic quality metrics and outcomes and how we are looking at fidelity using the Healthy Steps model. And then more into how we're sustaining our services and looking at how to scale those more broadly in California. So I just want to acknowledge the California Children's Trust and the incredible work that they have done in the area of children's behavioral health. This slide is from Alex Briscoe, and I have permission to share it. And I think it really sets up nicely where we have been. I don't think any of this is a surprise to folks, but to say there really has been a dramatic underinvestment in children, and in particular in the areas of prevention. California performs in the bottom third nationally for healthcare spending at $2,500 per child enrollee. In Medi-Cal in California, children represent 42% of enrollees, but only 14% of all expenditures. And California ranked 48th in the nation in access to care for children. And then a 2019 state auditor's report for Medicaid actually put California in the 42nd place in the nation in terms of preventative care services. So we have a lot of work to do. And fortunately, we are engaging in that work, and we're doing a lot of that, fortunately, here in the Bay Area. But this is a snapshot of some of the things that are going on in California. And so many of you have probably heard about CalAIM, which is essentially the state's efforts to reform our troubled Medicaid system in California. And there is a big focus on children's behavioral health. There's the Children and Youth Behavioral Health Initiative, which is really changing the way that our behavioral health system works for children. There's been a big focus on early childhood, both at the governor's level, Health and Human Services, as part of the Children and Youth Behavioral Health Initiative. And of course, we need to really call out the work of Dr. Nadine Burke-Harris as the first Surgeon General of California, and the attention that she has brought to the way in which trauma manifests into toxic stress and how that can be passed along intergenerationally. We know that the COVID-19 pandemic really highlighted a problem that was already there and made the situation even worse. And of course, we're seeing a lot of acute problems at the school age, adolescent, transitional age youth level. And so we're going to talk about young children and what we can do to prevent those things from happening. So I probably don't need to say much to this audience about why primary care and why pediatrics, but the summary is that in the first 3 years of life, we have an incredible opportunity to meet families where they are, to provide evidence-based prevention and health promotion services. Kids are coming into the doctor 12 to 15 times during the first 3 years of life, and we have a captive audience with their families and their caregivers. There are so many well-child visits that happen annually, and well-child visits are traditionally attended very well by children who have Medi-Cal. We also know that the primary care provider tends to be the first point of contact for any kind of behavioral health or social health concern. And so really an important opportunity to provide intervention support at those well-child visits and seeing that as the intervention context. We know too that half of adults with mental health disorders had symptoms by the age of 14. So really highlighting the importance of intervening early. And I think I'll stop there. Okay. And so now talking about the early intervention, early childhood system. Now, this is always a little bit surprising to me because there is so much evidence for early intervention and prevention science and what the cost savings can be when you intervene early. This slide really talks about how we have an unbalanced system of how we are where we are intervening, where we are focusing our efforts, and how the way in which we have historically involved families and caregivers has not been intentional and has not been in a balanced way where we're taking advantage of where families are coming. So again, the first year of life, they're coming to see the pediatric provider generally 7 times in the first year. And so this is now moving into the ideal state where we're really working to both in early intervention, early education, and early care settings, but also within pediatric primary care, kind of recognizing where does it make sense to bring families in, where they are interacting most with the different systems. So I'll talk about what we tried to do as a way to acknowledge this important opportunity. And starting from the ZSFG Children's Health Center, I started as the director of our pediatric behavioral health program in 2016. And I'll talk a little bit about kind of how we developed that program, but just to provide some context for the CHC, which I know many of you are probably aware of, but we are the largest single primary care clinic serving children with Medi-Cal in San Francisco County. We're a hospital-based QHC. We provide primary care, urgent care, and subspecialty care, have about 15 pediatric faculty and 26 UCSF residents, all who have a primary care panel. Very diverse patient population, with the Latinx population making up the greatest proportion of our patients, providing 32,000 annual visits. We have about 8,000 to 9,000 primary care patients as part of that overall 14,000. Half of CHC caregivers prefer to conduct their medical visits in a language other than English. And a couple of just social contextual factors. We did an ACEs screening pilot in 2018 where we were actually screening caregivers for adverse childhood experiences. And what we found was, not surprisingly, because this is kind of similar to national data, most caregivers of our CHC patients have had at least one adverse childhood experience in their own history, but almost half of them had experienced 4 or more ACEs. And we know that when you hit the 4 marker, that's when we start to see the real negative consequences associated with toxic stress exposure. We also know through an in-person and telehealth screening that we were doing earlier on in the pandemic, 1 in 5 of our families reported worrying about food running out, not having enough food, and having difficulty with having stable housing. So one of the things that we set out to do was to establish a behavioral health program within our clinic. Now, this had built on efforts going on for years within the clinic, but this was the first time that we pulled together a cross-departmental collaboration to really solidify a program that was centered in the CHC. And so this was a collaboration between ZSFG Pediatrics, ZSFG Psychiatry, and then the Department of Public Health Primary Care Department. And really, that's what I want to highlight from this slide. We have many partners that also informed the development of this program. One of the things that we did early on to make sure that we would be successful in this collaborative effort, because again, most commonly what you see with integrated behavioral health is to take a behavioral health clinician, master's level or doctoral level clinician, and kind of just plop them into the primary care setting. And what happens is that they follow the most acute needs, right? The kids who of course is the PCPs are feeling like they're most in need of help, most acuity. And very quickly, the behavioral health clinicians will end up providing essentially what is outpatient therapy in kind of a co-located capacity is how we describe it, where they're kind of the therapist down the hall. They're stuck in this like referral outreach loop, hard to really engage the families. And it's not taking advantage of working specifically in a primary care environment where you can do team-based care. And so this was the strategic plan that I led in partnership with Dr. Amy Whittle, who has been my partner in all of these efforts. And we established what our vision is, what our values were for the program, and really different domains of what we were going to focus on to make sure that we had a behavioral health program that was going to be population-based, was going to serve all age groups, make sure that we were able to provide preventative care, and integrate a number of different things, and also always with an eye on sustainability. And so this is this slide is where we are now. It's not the end point, but it's sort of the end to this beginning of the story. And essentially one of the things we did as a way to really target preventative care, team-based care, is to adopt the Healthy Steps model, which Chen is going to talk about in more detail. So I won't go into detail about that, but it's an evidence-based model that was specifically designed to do integrated care in pediatric primary care. And what we are at now, we have a little over 2,000 patients that are impaneled and consistently coming for well child visits, who are in the 0 to 3 age range at the Children's Health Center. And this is our data from last year, where our Healthy Steps team provided over 1,600 visits to about 1,100 unique pediatric patients. So we're serving over 50% of those patients, at least with one touch point. And then you double that, because when we're talking about dyadic care, we're also serving their caregivers. And so we're going to talk today about how we're able to do this, what the specific factors are in terms of sustainability and how to do this well. But the first thing we want to do is talk a little bit more about what is infant mental health, what is early childhood mental health, and how you do that in primary care. So I'll pass to my colleague.
Thanks, Kate. I want to take a moment to just lay out kind of the background and big picture for us. I feel like this audience already knows, but all the development that is happening in the first 3 years of life, it's really setting up the stage for later, right? And in that first 3 years, there's a lot of magical things are happening, and at a rate that will never happen again. 80% of the brain is really developed before age 3, and we know that the factors that really impacts that development, a huge part of it is the relationships, the context in which the child is living and hopefully thriving. And so we know that if we have emotionally nourishing relationships, we can have a strong foundation for later well-being. And the key to this is co-regulation. And co-regulation, as seen through the serve and return kind of model, in which when the infant makes a bid out to the world, whether it's for a need or a want, the parent is there, the caregiver is there to respond, and the child responds to that, and vice versa. And that interaction in itself creates and shapes the brain architecture, and allows for optimal development. Now, kids don't develop, in a bubble, and we know this, and we know that it's really important to look at the entire system. And so using that bioecological model, we recognize that not only do we want to, in our services, look at child and youth well-being, we have to look at the family systems, because if caregivers are not doing well, it's hard for kids to do well. And when we hold the family, when we hold that dyadic relationship, we want to look at the various variables that really impact them, and where are they living, and what is their community, and what is their school like, and their workplace, and the neighborhoods, and the values and the culture of their neighborhoods, and how does that impact the child. And that's why in a lot of today, we're going to really be talking about dyadic services, because we don't believe that we can just serve children and babies and kids in those young years, those early years, and make them okay if families are not doing well. So just for a moment, I want to focus on caregiver experiences. And we know that when caregivers experience ACEs, when they experience trauma that directly impacts the infant may not remember those traumas in the same way that us as adults remember them, but they do remember, just differently, and are impacted by it. We know that prenatally, right, if parents are experiencing a lot of stress and they have increased cortisols, for moms that might go through the placenta, and it impacts directly the child's development. And after birth, if families are struggling and really dealing with all these difficult experiences, it impacts the kids, it impacts their ability to feel attached with their parents. If families are not able to engage in that kind of going back and forth, the serve and return interactions I was talking about. And so we want to be able to facilitate that, because we know that kids who experience these kind of traumatic experiences later on in their adulthood are still being impacted by this. And this can also create intergenerational kind of patterns in communities and through a family system. Now, I love this model. We often call it the ice cream in a cone model, and it kind of shows the importance and the patterns of regulation and co-regulation in that early year. Infants, if you look at this diagram, it was really represented on the left side of it, where they have very little capacity for self-regulation and really need other regulation for every aspect of their lives, right? Like even sleep and wake, they need a caregiver to help sustain that and to create patterns and to be able to figure out their rhythms. And as they get older, their ability to self-regulate increases, but and their need for other regulations decreases. And we know that co-regulation is so helpful. One of the reasons is because of the toxic stress that Kate was talking about. For families who are going and experiencing really hard things and ACEs and trauma, we know that that amount of stress for kids, if we want to make it more tolerable stress instead of toxic stress, they have to be securely attached and to be able to feel like they're co-regulated. Now, I really believe that primary care presents this unique opportunity in which we are able to support kids and support families so that we can reach more optimal development. And why pediatric care and primary care is that place is because this is a source where families already feel familiar with and comfortable to go to for any kinds of help and support. 90% of families take their kids to the pediatricians, and they consistently tell us that pediatricians are one of the main people they feel comfortable and trust for their relationships. And also, a lot of families, a lot of individuals see primary care as one of the main, if not the sole ways in which they're getting mental health and behavioral health treatments. So they believe in the services being provided in their pediatric primary cares and are going there. And the touch points specifically within these first 3 years of life is so frequent, right? And so families are finding them there, and it's a great time to be involved. And we know that in order for families to co-regulate, especially if they're having a difficult time regulating their lives themselves, we really need the systems to come and wrap around them and do that holding. For early childhood, we have a lot of research to show that if we are investing in these services, there's a huge return on investments. From a child perspective, we see better social emotional development, we see better cognitive development, we see better life outcomes, whether it's in education or in occupation or reduction in adult crimes. We see better family systems, parents are more involved, there's less abuse and neglect. We see that parents are able to use more positive parenting guidance rather than punitive. We see a lot of different ways in which the work that we are pouring into in the early childhood years pays off, and in ways that if we did similar services later on, it's not quite the same. And so that brings us to the question of what does behavioral health and mental health look like in this time? It's different, I think, than our traditional trainings in mental health treatment, right? Where we have find a DSM-5 diagnosis, there's something clinically significant, so to say. And historically, that's the only thing that has been billable, and we go and prevent. You're not going to find a lot of this billable DSM-5 diagnosis early on. Instead, what we know is helpful is to be able to focus more on promotion and prevention, to being able to identify families that need more services, that may have more risk factors for different kinds of concerns, and to be able to go in, being able to give anticipatory guidance and be able to support families in knowing, okay, in these few years of life, there's so many milestones, so many changes in my child and our family dynamics. What should I be thinking about and looking forward towards, and to be able to be supported in that. There's a number of different evidence-based approaches to behavioral health care for infants and early childhood kids. Some of them are parent behavioral therapies like PCIT or Incredible Years or Triple P. There's also trauma-focused interventions like TFCBT and CPP or attachment vitamins. For primary care, there's two main ones that are practiced and have a strong source of evidence. One is Healthy Steps, which I will talk about, and the other one is Project Dulce, which is also an integrated form of care with behavioral health components, but really focused on kids 6 months and under. Now, Healthy Steps. Healthy Steps was established in 1995. It's a national program in which really trying to promote more integrated approaches to supporting families and kids in primary care programs. They really target families from low-income communities and historically marginalized communities, and do so by having a Healthy Steps specialist come and join the pediatric team. Pediatricians, they have so much on their plates in such short amounts of times when they go in for all these well child visits, and it's hard. They often share with us how hard it is to get through every aspect of development or all the family needs. And when through this model, they often share, especially in our clinic, that they feel like they can share some of that burden with us because they know we will hold a lot of the behavioral health or developmental health components right alongside with them. And so what does this really actually look like? And so in a clinic, again, Healthy Steps nationally is 0 to 3. We have had the privilege in our clinic to expand that to age 0 to 5. And so for our families 0 to 8 with children ages 0 to 5, we provide different services based on needs. So we want all our families to feel supported first and foremost. And I see that as our tier 1 services and universal services. And that really looks like making sure we have screenings available, right? Screening for development, caregiver mental health screenings, making sure that we are able to touch base with each family to know if there are specific needs for us to support with. It also means looking and making sure they have access to developmental materials and other kind of materials and knowledge. Tier 2 is more short-term kinds of supports. There might be a more acute presenting concern that we're going in supporting the family with. And then once that concern is resolved, we might step out. And so things for that might look like if there's a failed ASQ, right? We might go in and talk about, okay, where is your child developmentally based on what you're sharing with us, and where would we like them to be, and what do we do about it now, whether it's connecting them to regional center, or I might talk through with them some things they can do at home. It might look like toilet training. They might have a difficult time. This morning I was talking with a parent about toilet training and establishing bedtime routines when it's really difficult for the family, and really just supporting them in problem solving and giving some of those knowledge to them. So we're going in, we're seeing them until this problem resolves, and we're stepping out. And this is in the context usually of when they're already coming into clinic. And we might do follow-up calls as necessary or visits. Tier 3 is a little bit different. Tier 3 is really heavily focused on that prevention. We identify families right from the get-go, and ideally in the newborn stage, and we know that this family might benefit from continued services. And in our clinic, we've identified that as families who might have had a very difficult birth circumstance, or a NICU stay, or it's a teen parent, or they're experiencing homelessness, things that we know that traditionally are very hard for families. And these families are usually ones that really benefit from additional holding and support. And we want to do that. So every time they're coming into that clinic, especially for a well child visit, we pop in. There might not be a concern, right? There might not be acute something going on, but we want to jump in, say hi, make it, let them see our faces, because sometimes seeing a psychologist can feel really stigmatizing. And so we want it to be really normal that they're seeing us, and we want to give them support. So if they have questions, answering those questions, but if they don't, talking about anticipatory guidance, saying like, oh, what are temper tantrums? Are they normal? How do we deal with them? Or separation anxiety, how do we think about that as their child is enrolling into childcare? And just giving that knowledge ahead of time so that families feel really supported as they're progressing through these milestones. And in addition to this, we really try to bring a dyadic perspective to all of our interactions with families. And so, for example, you might talk about, like I was saying, sleeping, right? We often, if their parents say sleep concerns, historically, you just jump in and target that. But with that dyadic perspective, we want to see the impact on the family system. So this morning, I talked with the family about their bedtimes and how has this impacted them and their sleep, and how does that impact their stress and mental health. And so really being able to take that step back, or if it's breastfeeding, right? Whether it's difficulties with breastfeedings or weaning or things like that, we recognize in the room that the parents are going through this too. It has an emotional effect on them, and exploring together what that emotional impact is and how can we navigate it. And so really being able to acknowledge that their child's development is also really tightly interwoven in theirs, and really supporting them and taking care of themselves as well so that their kids can do well. This is our data from our clinic from the last year, our common presenting problems that families are coming in. And so as you can see on the bottom, the most frequent one is actually just typical developmental issues, things that we're not actually that concerned about necessarily, but we're going in and doing health promotion and doing support. Second of all is caregiver mental health issues and family circumstances, so like homelessness or resource needs, etc. These are not, again, the things that traditionally, right, that we're doing as behavioral health necessarily and billing for, but they are the things that we're finding families need most. And I would say that this is not just true for having a Healthy Steps program in the clinic. Before our Healthy Steps program was implemented, these were still very similar to the referral concerns that our pediatricians were giving us, knowing that the family system was struggling and wanting behavioral health supports with that. And so I think this is consistent whether or not clinics are having Healthy Steps. And here on the white are our enrollment reasons, some of our enrollment reasons for Healthy Steps within our program. And so you can see a lot of it focuses not just on the child, but also on the entire family and the system, whether it's child welfare involvement and wanting to step in there, or a family stressor, or a caregiver behavioral health concern, or a family with ACEs. I think it's really important to recognize that what this looks like in daily life, which is when the families come into the clinic, we sometimes jump in, right, with the clinician who is already there, the primary care physician who is there. We jump in and we might have a co-visit, or we might come in before or after the primary care physician is there, the PCP is there. And we want to be able to support that workflow. And we're doing it in a way that is more trauma sensitive. We are sensitive to it, and we are a familiar face that they are seeing. So we're going in, whether it's with the vaccines or with other aspects of their care, we're there to hold that and to have a conversation embedded within. And then being able to support them in getting resources out there. It's hard in our systems, as you guys might know, to connect our families. And it's not always successful the first time you send them there. And it's really hard for families to do that. And so we sit and we understand and we try to support the team in knowing where the family is at, and family and understanding the system, and doing that care coordination as well, and getting families connected. So that's a little bit about our work. And I'm going to pass it to Kate to talk a little bit about outcomes.
Thank you, Chen. I'm just sitting here reflecting, because I'm always just thinking about how is this landing? How is this feeling beneficial to this particular audience? And I think some of what we really want to kind of drive home, because we know not everybody is lucky enough to have integrated behavioral health with them working alongside. We know that not everybody is working as primary care providers. And I think, first of all, we have some good news about in terms of what is coming and what is available at the state level to be able to increase access to these types of services. But one of the big points is that it's really common to encounter struggles of caregivers, struggles of parents when you are working with a child. And the pediatric providers that I've talked to generally say they don't get that kind of training. It's hard to know exactly how to show up or what to do. And we know that we have places we can refer them to. We also know that most of those places are really hard to get into if there's access. Parents are probably juggling a lot of different things that may or may not make them be able to access those services, even if there's a slot. And so part of this is about thinking about how to leverage primary care as a setting where parents can come and seek support. And there's not always a simple solution, but just to draw upon an example of a colleague of mine who I was talking to that was talking about her 2.5-year-old who was having tantrums and major separation anxiety every single morning, and like horrible separations as she was dropping her off at the childcare setting. And you can imagine that's hard for any parent. But if a parent, let's say, has history of neglect, or for some reason that we all have triggers as it relates to this stuff, that kind of crying or that kind of separation anxiety is really pulling on us. And so parents deal with that in different ways, right? And in the way that they cope, and so it can sort of, you can imagine it can lead to this cycle of how parents interact with their child and how patterns become really entrenched, and how, of course, that's not going to be the only thing, but this is how mental health disorders start to develop, right? Both, internally, biologically, but also influenced by our environment and our relationships. And so I asked my colleague, I said, does she know, because she works part-time, and the child only goes to daycare part-time. And I said, does she know when she's going to go to daycare? Like, does she have any sense of her schedule? And she said, I don't know. And so we talked about, well, this is how you might be able to kind of map it out for her at a 2.5-year-old level, so she can understand where she's going every day. Once she made that schedule, the separation anxiety stopped, the tantrum stopped. And like I said, it's not always going to be that simple. But if it's not just about giving behavioral guidance, like, well, ignore the tantrum, or the separation anxiety might be normal at this age. It's like really thinking about what is the context here and working with the parents to implement something that feels attainable to them. Then smaller little things can actually be really effective. And so that's why we talk about prevention and health promotion, because it can have a huge impact earlier on to prevent these cycles, right? These trajectories of how developmental consequences happen. And so I'm going to talk about some of the outcomes of our program. But before I talk about the numbers, I want to talk about the qualitative information. And so just going to share 2 quotes from our caregivers who participate in our Healthy Steps Tier 3 program. And she says, "I think it's a wonderful program to have an extra person to talk to, and not just the pediatrician. Yeah, it's about the baby. You go there for the baby. But to have them talk about you as a mother, it also helps, because, we're taking care of them, and getting our feelings out helps us to be better parents for our kids. I thought talking to them was great because I felt heard and not brushed off." And this one's reflecting and says, "The talks that we had empowered me to be strong. There have been times where I didn't have anyone to talk to, and I think about what my Healthy Steps specialist said." So again, it's hard to always grasp like what these little things that we do in the visits can mean. And again, for a caregiver, a family member who does not have anybody else or other source of support, the talks that we have can go a really long way in helping them to cope and manage their very stressful circumstances. We did a survey and interviews with 21 providers. The survey was for 21 providers, both at Children's Health Center and Southeast Health Center. And so this just highlights a little bit about feeling like the Healthy Steps program is beneficial to their practice, that working with Healthy Steps improves the care that they provide. They're confident when they refer to a patient to Healthy Steps, the specialist will help to meet the patient's needs. 90% had said that. And then I find this quote to be very powerful from a provider at the CHC. "The support from Healthy Steps has dramatically improved the care that I provide to my patients and their families. Before their involvement in the clinic, I often felt overwhelmed by the needs of my patients and stressed by the limited time I had to try and address them all. Now with Healthy Steps, I know that I don't have to try and address everything alone. I know I can provide a warm handoff and start my next appointment with the knowledge that my patient will be in good hands. I would particularly like to call out Catherine Hallinan. She does an amazing work, and I have learned so much in our time caring for families together." Okay. And for the sake of time, I'm not going to go in depth into these outcomes, but just to say the evidence base of Healthy Steps, which really, as you saw, it's a infrastructure, it's a risk stratified infrastructure of population-based primary care. And so when we have all of these pieces in place, we find that we see improvements in screening and connection to services, practice and provider impacts, improvements in symptoms of maternal depression, social emotional development, et cetera. And we see these outcomes both at the child level and at the caregiver level. It's also worth mentioning that the work as part of CalAIM, Children Youth Behavioral Health Initiative, all the reform that's happening at the state level right now, the Healthy Steps metrics really do align with the bold goals that DHCS, California Medicaid, has set out in terms of improving care and closing disparities and improving health inequities. And so looking at improvements in well child visits and immunizations, for example, screening and care coordination. So just like to highlight that, and it also speaks a little bit to the work that we're starting to do at the state level to scale this model. So again, I'm not going to go through this, but here's the tiers of Healthy Steps. And to just show, again, our population-based approach to care. And so this is just an example of an afternoon in clinic. This was for a resident continuity clinic. There were 29 patients coming in, ages birth to 18 years old. We were engaged, 23 of those 29 were 0 to 5-year-olds. So again, part of our challenge with behavioral health is that it's hard for them to access the care, and then it's also hard for us to engage them. So the beauty about this setting is they're already there. And so we have 16 of those patients in that tier 1 bucket where they're getting universal practices. This is standard pediatric care. It's developmental screening and the interventions that you would have as part of Bright Futures. 3 of those 23 were enrolled in tier 2, and then 4 were enrolled in tier 3. And Chen already went over this, but our criteria for tier 3, where we're automatically kind of in a shoulder to shoulder environment, planning to join their well child visit either before, during, or after the provider is there. And these are our reasons for enrollment. This is an example of a resident project that was taken on to improve caregiver depression screening using the Edinburgh postnatal depression screener. And so this was one of the very first things that we did when we started our Healthy Steps program, was make sure that the Edinburgh was being done as it was meant to being done in a standardized, universal way. And so seeing improvements there from like the 50 to 60% rate of screening up to 85, 90% consistently. And then our workflow is that when there is a positive, we reach out to a Healthy Step specialist in the moment. And in most cases, they're available. There are some times when they are not, and then we make a referral to our team. This is also something that we've looked at, and there's a little bit of error in this data because it's always challenging to refine how we're getting data from our Epic medical record. But you can see sort of generally how we're monitoring ASQ, developmental screening rates, MCHAT screening for autism, and then the EPDS is the maternal depression screening, and about what a % of positivity rate is according to those screeners. So part of what we have to do with Healthy Steps is report to the national organization on an annual basis because they track fidelity metrics. And so this is one of the ways that has allowed us to really focus on a data-driven approach within our pediatric clinic, which is not always easy to do when we're juggling so many different initiatives and requirements. Over the past 5 years, we have increased these 3 in the patients that we've served. And so you see the 1609 is patients served, ages birth to 5, visits, 1609 is the visits provided, 1138 is the patients served, and then 746 of those visits were team-based well child visits, where we're meeting them in the well child visit environment. And then finally, the Healthy Steps specialist plays an important role in helping to better coordinate the system of care because it's a very fragmented system, very difficult for us, for families to navigate. And so they don't have a magic pill or anything that they do to make that better, but they can help the provider not to feel so scattered and sharing the need for care coordination and bringing our systems together. And this is our fidelity metrics, which I won't go into detail about this, but just to say, I think it just really, we're looking at how to sustain Healthy Steps in our program at ZSFG now. And some of the feedback we've gotten is because this has a framework, it's an evidence-based model, it gives us something to kind of hang our hat on and understand. And I think it's really important to acknowledge the accountability that we have to demonstrate in terms of reporting to the national office and then looking internally where we are with quality. And so the 3 number is basic fidelity, and then the 4 number is optimal fidelity. And so this just kind of shows how across the tiers where we've grown and how we're operating to fidelity at this time over this past year. Some of this is about data reporting too, which we've finally been able to improve. All right, so now I'm going to talk about sustainability. Because again, I'm sure that folks are thinking this is great, but how do we get these people, these people are not always available, and how do we integrate them into our clinic? And so one of the things we did is start to build up our behavioral health team. Now, all of these folks are not clinicians. The top row are our frontline clinicians, or our like family navigator or our behavioral assistant. And this is a combination of UCSF and Department of Public Health staff. The middle row is our program administration, our learners. And then the bottom row is the variety of folks who serve some sort of a leadership or administrative role within our program. And so it really takes a village. This is all, a lot of this is partial FTE for the most part, but just to acknowledge that we've been so lucky, in large part to funding from the Stupsky Foundation, shouting out Onda Quo and Dana Long for their efforts there as PIs of that grant, and to really support us in funding to build up a team like this. So as mentioned here, we've done this with grants because we've never been able to bill for this kind of service before, because babies don't have diagnoses. Sometimes they do, right? But when you're intervening with their families, they typically don't. And so the red boxes here are those staff that are fully grant or donor funded. And so here's the thing, and I just kind of alluded to this, but when we collect data on what our presenting problems are for behavioral health services, we break that in, we divide it between 0 to 5-year-olds and then those that are 6 and older. And as you can see, the patients that are 6 and older, no surprise, their primary presenting concerns are going to align more with what would be a DSM-5 billable diagnosis. So depression, anxiety symptoms, behavior problems. Whereas when you're looking at the littler kids, it's much more environmental, as Chen already went through. Family circumstances, caregiver mental health. So there's not a diagnosis, well, there's not a billable diagnosis for postpartum depression. There is a P code that says newborn affected by postpartum depression, but it's not billable. And so the issue is that these drive billing, which drives sustainable positions, and the ones on the left never have. And so when you look at that, this is what would happen to our behavioral health team if all of that grant funding went away. And so this is why we were so motivated to look at a sustainability option, because otherwise all of those, 1,100 patients times 2, right, for each of their caregivers, those services will go away. And so what we did was we worked with our health plans locally as a part of a working group called Tonic, and essentially help them to understand what the gap was and why this was such a problem, that we were providing services we couldn't bill for. We didn't have a sustainability solution. And essentially what they did was invite us to propose how could we bill for this? How could we make this sustainable? And so we wrote this paper, this proposal to San Francisco Health Plan and Anthem, called Babies Don't Go to the Doctor by Themselves. And we essentially crosswalked CPT codes to the Healthy Steps model and proposed a way to do this. And we got lucky in terms of timing, because obviously the state saw this is a way to respond to elevated ACEs screeners, and to really build off of what we're trying to do with CalAIM and the Children Youth Behavioral Health Initiative. And so we got kind of lucky in terms of timing. And also around the same time, the state put out a new version of the family therapy behavioral health benefit. And what they allowed us to do for the first time using this benefit was to have a Z code be the primary billable diagnosis. And so what that meant is for the patient ages 0 to 20, if they had these risk factors on the left, on the blue box on the left, then you could bill this Z code. Or if they had a caregiver that had the risk factors on the right, then you could provide family therapy. And so this opened up a really nice opportunity to be able to start billing for prevention when these risk factors are present, or when you're working with a family member or a caregiver in service of child health and development. And around that time, because of the work that we were doing locally with our pilot, and because of the goals that the state had, they reached out to us and tried to understand a bit more about the work that we were doing, and invited us to propose a new Medi-Cal benefit. So one of these really amazing opportunities that, again, only comes with the right timing and the right partners. But essentially what happened was we created the new Dyadic services benefit alongside the state. And one of the things that was created as part of that benefit was a behavioral health well child visit, a dyadic behavioral health well child visit. And so it took away the need to have a diagnosable mental health disorder to be able to receive behavioral health services, and really even removed the need to have risk factors. And this is where we're talking about, this is a benefit that is available for every single child who has Medi-Cal across the state of California. And it's social emotional inoculation. So for us, our vision is that getting mental health support at the newborn visit, at the 2-month visit, even prenatally, if we can get there, is just as normalized and non-stigmatized as getting weighed or getting your vision checked. And this is how we can really make an impact. And so Governor Newsom allocated $800 million over 5 years to the implementation of these benefits. And we were really excited to see that the dyadic benefit was able to expand beyond family therapy, where we were not looking at risk factors. We were also looking at non-traditional therapy options where you don't have to have a 50-minute session, but you're able to go in and provide psychoeducation for 5 minutes and bill for that. Or you're able to do a curbside consultation with a provider and bill for that, because we know that these are the kinds of things that make a difference when we can put our heads together and think about what our patients need. This is a list of provider types who can bill for these services. I won't stick on this, but I think these slides are shared, and this is a link to the manual if anybody wants to learn more. But essentially it is for credentialed behavioral health providers that are able to provide dyadic services as part of the non-specialty mental health services benefit. And so now we are in a position to think about, great, we have a benefit, it's definitely the right thing to do, but how do we get people to access it? Families don't know about it. Clinics don't really know about it. We all know that the behavioral health workforce is pretty much dedicated to really acute level needs. And so it's really about transforming the way that we provide care. And so it will require a lot of support. And so because of that, and again, in partnership with Dr. Kuo, Dr. Long, the folks at Children's Health Center, we've been able to develop a technical assistance center that is really based out of our Healthy Steps team at the Children's Health Center, where we're kind of using that as those are the services we're providing, but it's also an opportunity to learn and develop best practices for implementing these types of services. And then we're working with counties and other systems across the state to be able to disseminate those best practices. In terms of what we have been focusing on, and in terms of what you might see different health systems needing, this is what we would highlight. I know this is a lot of words, but really a need for socializing the benefit, educating what is available, and engaging leadership to be excited about this opportunity. Support with clinical services implementation, both to the clinical workforce and to both medical colleagues, behavioral health workforce, highlighting the importance of data reporting and having that infrastructure, and really following the evidence base and using that as a way to drive our practice improvements. And then of course, looking at sustainability, which requires partnering with health plans so that you can get to the point of moving off of the initial seed funding into a more sustainable service. I'm gonna skip through this, and in terms of Healthy Steps is a great model. It's not the right size for every practice. We have some clinics in San Francisco that have 40 children in their practice, but they really want those kids to be able to access this type of service. And so it's a matter of how do you think about that and where can you start? Because that's also partly what we're seeing is it just feels unattainable to think about delivering this whole package of dyadic services when you're basically starting from zero. And so part of what we're talking about with practices is just picking a starting point. Are you doing caregiver mental health screening in your practice and really recognizing the value? We see a lot of fear in, well, what's going to happen? You know, we don't have the ability to support caregivers with mental health. We won't know where to refer them to. And so that's something that we need to talk with folks about in terms of how that will be managed within the clinics, but it's a starting point. Or maybe it's developmental screening, and what is sort of the way in which kids are going to flow through your system who have developmental concerns. So these are just some of the points of things that we have recommended in terms of what are the steps to be able to onboard to a service like this. And then it's worth mentioning that there are many other aligned initiatives at the state level that really interact nicely with the dyadic services. And so enhanced care management, which is a service of CalAIM, is one of those in particular. And so, for example, The children and youth population of focus just went live in July for CalAIM. And part of the issue is that the health plans can't identify the kids. We know there's a workforce problem with enhanced care management, and that we need to be working on that. But we also know, because kids don't have diagnoses and the health plans are not mental health diagnoses for the most part, and the health plans are not aware of them, then they can't really identify those kids to send them for ECM services. And so we have used our Healthy Steps program and Dyadic services as a way to have those kids on our radar and refer them to ECM services. And so similarly with some of these other initiatives, there's a lot of overlap. And I think working together and breaking down silos of how the programs are implemented is how we're going to be most successful. Okay, I think I've gotten to the end, and we'll open for any questions. Thank you. Dr. McNamara.
Thank you so much for your really impactful work. It's nice. Really to all the providers to have colleagues too. Two questions, and they may be beyond the scope of where you are right now, but one I'm wondering about, particularly since this Healthy Steps program is in other places. Have they been able to track, sort of look at diagnostic or other to further justify this early detection work, or perhaps the other thing is just more of a investment that the state is willing to make monetarily for large chunk.
Yeah. So if I could distill the questions, right? I should be repeating them. Thank you for the really important questions. The first question was about Healthy Steps longer term outcomes in terms of just impact on disease development, right? And psychiatric disease development. I have to get back to you on that. I know there have been some small studies, but what we haven't seen with the Healthy Steps data is like big scale replication. And so the outcomes have been more focused on more shorter term, linking to care, and then the way in which we know that improves health. But I can't refer specifically to anything that you're asking about right now. And then the other question was about how is the state going to build up the workforce to be able to provide services? And that extends to the community health worker benefit and the doula benefit, and then thinking about dyadic services. I don't have a great answer for that question. I mean, I can say the reason that, and we have that question too. The reason that we have our technical assistance center is because the state developed this amazing and very right and needed benefit. And yet there's not really been a plan for how to support implementation. And I can tell you that at this point, there have been, in conversation with our health plan partners, virtually no claims on Dyadic just yet, which launched in January and does require some implementation support, but that is a gap. And I think there's just so much going on at once right now that folks are having a hard time taking it all in. What I can say is those of us that are doing this work is this benefit is one of the biggest things to happen to kids in behavioral health in our state, and it's trying to be replicated nationally. And so it's a really big deal. And I think what we're trying to do is talk about demystify a little bit the perception of workforce, because the nice thing about this is, yes, I don't want to underemphasize the need for child development expertise and how important that is. And we are working with caregivers. So this is a big reason why I say, let's start with caregiver depression, because we can at least bring in adult providers who are trained to do that. Not that they're coming out of the woodwork either, but there's a way in which I think we're not in as dire straits as we think we are, particularly with dyadic benefit. One of the things we're advocating for that was not done as part of this benefit was to allow for unlicensed providers do the care coordination and some of the other things that we know they can do really well. And that was not something that was approved as part of the benefit yet. So I guess the last thing I should say is, as it relates to FQHCs, there was a big Senate bill that was passed about a year ago that allows for associate level MFTs and clinical social workers to be able to bill as FQHC providers. That's not really well-known knowledge, but this is the opportunity to take advantage of the folks that are just coming out of master's level training programs, train them up, help them earn their license, their hours for licensure. And it is a big improvement in terms of being able to access that, tap into that workforce.
I think we're out of time, but I never can totally escape an opportunity to point something out that as someone who's been raised and born and raised in a country, a European country with a very different approach to preventive healthcare services, where neighborhood clinics, neighborhood centers staffed by nurse assistants mostly, and then school clinics staffed mostly by nurses and psychologists do all of the preventive healthcare and screening. And so I'm wondering very much, as you advocate at the state level and do all of this work, to what degree there's actually a thought to take some of this work out of the hands of the relatively highly paid, lowly paid pediatricians as physicians, but the highly paid clinical provider workforce into a workforce that can be scaled up, hopefully much easier for the lower price tag.
Yes. Yes. In full agreement. I mean, and one of the things I like to also say is this is still a reactive. It's preventative, but it's still reactive, because if we were capacitating our families and our communities better, then they wouldn't need to get this at the doctor. So yes, and I'm in full support.
Yeah, and interestingly enough, our training accreditation bodies for pediatric clinicians are actually also, now we have to be good at diagnosing diseases, treating diseases, preventive healthcare, mental health care, you know, and I think we're just creating people who are not that great at anything, instead of using other people to do this work.
Yeah.
So, but thank you for all the good work and advocacy and for presenting.
Thank you so much.